The use of stem cells to treat various medical conditions, including joint pain, is gaining more and more awareness, with more patients coming through having questions about them. So how should we go about answering them? Well, on this episode of Clinical Communication, I'm joined by Dr. Ansar Mahmood, who is a consultant orthopaedic trauma surgeon and also American board certified in regenerative medicine. He is the orthopaedic trauma research lead at the University of Birmingham and is the immediate past president of the British Trauma Society. And on this episode of Clinical Communication, we're discussing how to address some of the common queries that come up with stem cells, what they are, what they do, some of the misconceptions, what they might achieve, and what the future may look like with them. If you find this useful, please do go subscribe and please do go share it with others. You can find Dr. Mahmood on Instagram and LinkedIn. I'm across social media at BYBrowPhysio. You can send in emails to clinicalcommunication@outlook.com. Thank you as always for watching or listening, and I'll speak to you soon. Right, sir, I will start this with, before we get into the current of what stem cells are now and what we do with them and what the options are for pain, what's the backstory? How do we get to where we are now with stem cells being part of healthcare and potentially growing more into healthcare?
Well, stem cells, in simple terms, it's the mother cell, right? The mother of all stem cells is the oocyte, right? It's what made all of us. So it gets fertilized by the sperm, and then it generates every organ and every cell in your body. So that's like, the most amazing stem cell in nature. But stem cells were actually, I mean, we probably had an understanding that there was something called a stem cell in the early 19th century, or probably late 19th century. I think when people started studying germlines of cells, they started coming up with the concept, well, actually, these germlines seem to come from somewhere, but they hadn't yet identified stem cells. And then in I think 1960s, somebody actually isolated the first stem cells from animals. And then there's the sort of story starts there. And then the first stem cell transplant, if I think, was done in about 1960, maybe in 1958, 59. Somebody did a first stem cell transplant, which was bone marrow. So the first primary stem cell niche that was found was bone marrow as being rich in hematopoietic stem cells. So they found that, as early as World War II, actually, they were doing radiation poisoning studies in World War II. So going back even further now in the 40s, and they actually found that when they radiated people, their bone marrow, you get a huge bone marrow suppression, but it recovers. And at that point, they were saying, well, they're recovering because there's something in the bone marrow that's causing the recovery, and all of the cell lines start to recover. And so they hypothesized at that time that there must be some sort of a cell in there that's an originator cell, as they called it, that creates a regenerative effect on all of the bloodlines. But they hadn't isolated them, so they were isolated much later. And first stem cell transplant happened from bone marrow in about 58, 59. And then, the story then goes on, and they started to then isolate and be able to understand cells a bit better in the 80s and 90s. And the first big professor that actually showed the huge potential of stem cells, I think, was Professor Yamanaka. And that was around 2006, not that long ago. He actually showed you could program these cells. You could switch them on, switch them off. You could actually have a mature stem cell, say a bone marrow stem cell. You could program it so that it went back to a prior form and became. And he showed a way where you could change the functioning of a stem cell. So, there are cord stem cells or umbilical cord. So, very what we call pluripotent stem cells. So they already have the generic ability, as they need to have in a baby, to make eyes and organs and hearts and bones and everything that we know about and almost take for granted. And those pluripotent stem cells are there. But actually, as you become an adult, those stem cells tend to find their own niche and lineage. So we then, as adults, we don't tend to have many pluripotent floating around stem cells per se. We tend to have bone marrow for bone. We have tendon, cells for tendon. We have, ophthalmic cells for the eye, and so on. But they've sort of got their own matured lineage, so they can recover and heal. They tend to recover and heal that particular area, right? So the eye, or the bone, or the blood, or the or different tissue. And what Yamanaka found was actually you could take some of those cells, say like bone marrow stem cells, take them back a little bit, reprogram them, and make the bone marrow stem cells make skin, for instance.
Oh, right.
Use skin to make bone.
Yeah.
So they had the ability to be altered in their programming. And that was
Oh,
what was fascinating. Is they thought, well, actually, so if you then take a cell that is a very intelligent cell, stem cells differ from, say, platelet-rich plasma in that they have a brain, they have a nucleus, they have these receptors on the surface. And when they drop into an area, they also are described to have something called a homing mechanism. So when they drop into an area where there's a problem, they actually read the environment. And when they
oh,
read the environment, they pick up signals, usually inflammation or cytokines or whatever it may be that's causing the problem there. They read that environment and then they release a signaling mechanism. And that's where, Arnold Kaplan, who was one of the pioneers in stem cell research and clinical use, he was actually a scientist rather than a clinician as such, but in California discovered some of the earlier stem cells and how they formed and functioned. And he actually rebadged them because he said, when people talk about stem cells, there's a lot of confusion. He said, but ultimately, most mesenchymal stem cells, so these are the adult lineage ones that you and I and most people have, are medicinal signaling cells. So rather than calling them MSCs, mesenchymal stem cells, which means different things to different people, he said they should just be medicinal signaling cells. He said, because that's all they do. They actually drop into an area, read the environment, and then send out loads of signals. And that signal ultimately is to try and cure or fix the problem. They're trying to improve the integrity of tissue, re-heal tissue. And actually, the way they work is quite interesting because people assume stem cells go in there. And if you watch a Google video, everyone has the idea that the cell's gone in and, oh, I've got a cartilage defect and arthritis. So the cell is now turned itself into a cartilage cell and is now making new cartilage and rebuilding my knee. In reality, that doesn't happen. So what actually tends to happen is that they read the environment, they dampen the inflammation. The mother of all disease is inflammation, and so they often act as a predominantly anti-inflammatory. But then they also send out little signals where there's abnormal things happening, and they dampen those abnormal things and try and create normalization. And so one of the things that the beauty of the growth factors generate is that they target they don't make it, they're not super serums, they don't make it bigger, faster, stronger. They actually just want to normalize what's going on. So they try and send out signals to create a more normal hemostatic environment, because there's currently inflammation and mischief, and that leads to pain and so on. And that's why they work. That's why they work for conditions like arthritis, because they dampen the inflammation in that area. And then they will release signals. Those signals are usually tiny little cytokines or proteins. We call them exosomes or EVs, extracellular vesicles. And they'll go out, and what they do is they actually get the other tissue in that area to wake up and do work. Because sometimes you wonder, I mean, when you actually look at the basic science behind stem cell work, you almost wonder why anybody gets any disease, because there's the presumption I had when I first entered this area is, oh, there's no stem cells, and that's why we have to put them in.
Yeah.
And then I went and studied a bit more and learned about 15 years ago, and through my reading, I thought, actually, there's like millions of stem cells everywhere. And even within a knee, you have an arthritic knee, and within the synovium of the knee, there are millions of stem cells just sitting there. I don't understand why they're not partaking in the recovery of the body. They sort of
Interesting.
sit there, and whether it's cell senescence or what, they'll sit there looking at the joint almost and do nothing. But they can be stimulated and turned on. And that's what part of putting in activated stem cells or PRP, platelet-rich plasma, which is a sort of a stem cell-like treatment in that it releases growth factors, and part of that growth factor release actually activates senescent cells, or will activate stem cells and macrophages to work harder. And there's beautiful little electron microscope diagrams showing that when platelets break down as part of the PRP response, they actually release their mitochondria. So little battery packs of the cells are released, and nanotubules from the other large cells around them, like monocytes, they pick them up. And so it's a bit like recharging your own batteries. They pick up, and so they then start to work harder because they've been recharged, and they get receiving all these growth factor signals and proteins saying you need to heal, and so they try and restore the integrity of wherever tissue they're around. So it's fascinating, you know, the more you look into it, it's a bit like a Russian doll, the more complex it gets, more infinitely intricate it gets.
Yeah.
You know, and that's where once I started reading this, I thought, God, we're never going to understand this. You know, maybe in 100 years when science has evolved, we don't even have the instruments currently that can measure what these cells are doing.
Really?
Yeah.
Ah.
We are working on it, but we're constantly evolving. We're, you know, almost cell reaction by cell reaction going, oh, can we measure this? And what we're actually doing is, you know, we can't look under the hood of a cell and go, oh, you're doing this. What we end up doing is a bit like having a car with an infinitely complex engine. And all we're currently doing is saying it's working okay by measuring the exhaust fumes. So
Oh, right.
the best stem cell laboratories in the world are currently basically measuring exhaust fumes
Oh,
and then saying, well, you're outputting this, so it's okay. And the cells are working, and that's yeah, the level of a crude level of research that we're at, and we know loads. You know, when you read
yeah.
all the research papers on stem cells, you think, wow, we are really getting there, and then you realize it's like you're scratching the surface. You know, we've literally, you know, covered
Really?
1% of its function. Um, and so it's a fascinating area. That's what I really enjoy about it. It's evolving all the time. You know, in trauma, I've been a trauma surgeon and studying and teaching or working, you know, since when I started in trauma, I was 2004, 2004,
Hmm.
but over 20 years. And
Yeah.
to be honest, we haven't evolved much in 20 years.
No?
We use plate screws, rods, nails, same
Yeah.
physical principles. We operate
Yeah.
on people in the same way. Yeah, we probably got slightly fancier screws and slightly shinier metal, but the principles are the same.
Mm.
And our results may be 5% or 10% better. You know, in 20 odd years, I haven't really evolved my practice enormously.
Really?
It doubled in its quality maybe in 20 years. But with stem cell research, you know, it's leaping forward in almost exponential terms.
Oh.
And it has to be the future, really, of the way a part of the human condition. You know, it's gene therapy, cell therapy are going to be what cures diseases ultimately for us in
Mm.
the future. You know, whether it's Alzheimer's or degenerative disc disease, um, cancer. It is modular. Once we understand the cell properly and how to
Yeah.
program it, alter its programming, affect the genome within the cell, that's going to be the future. And we're either going to kill ourselves by creating COVID 1999 or whatever, or turning everyone into zombies like the zombie apocalypse movies, or we're going to start curing some seriously problematic diseases.
Mm. It sounds like that the cell, when you put it in, it kind of works like a mini little paramedic in a way, kind of
Yeah,
getting to the issues and I'm saying mopping it up, but like, but trying to activate and change various things to improve the outcome in a way. Do
absolutely.
do
That's
we
a
know?
good description. Yeah, it's a well-trained paramedic, but it's working and it's working in a relatively familiar environment, right? So
Mm,
it's in its zone.
do we know why so many of these cells sleep?
Simple answer is no.
Okay. Mm,
There is something called cell senescence, and that's
mm,
where cells are programmed not to be as active, and we don't 100% know that. The body will senescence is really important. If you're a cancer doctor, you'll realize
mm,
how important it is, and the reason is that if a cell is not for some reason functioning, or your body feels it shouldn't be functioning, is not functioning optimally, it will
mm,
put it to sleep, and then
yeah.
sometimes it will put it to sleep to a point where once the cell degrades to a certain point, it undergoes apoptosis, which is programmed cell death. So it kills off cells, and that's why your cells renew, and there's always a cycle, right, of renewal, death, and new cells being produced. Your body's not static, it's always producing new cells. And senescence is part of that cycle. And so if you didn't have senescence, you probably have far more mischievous cells that might turn into cancer cells floating
Mm,
around. And so
mm,
it's part of that state. Also, if you're inflamed or you're biologically suboptimal,
mm,
for whatever reason, you know, there's lots of research going on in this space, but um, your cells may also become senescent. So you have a higher level of senescent cells compared to somebody who's fit, healthy.
mm,
Yeah, and as you age, the senescence increases. So we know it's part of the controlled inflammation part of your body.
mm,
If that inflammation gets imbalanced, senescence may increase. Arthritis may just be seen as something that's, you know, bit overwhelming for the joint. And so the cells sort of look at it and think, well, we can't deal with this.
Mm.
or maybe they just haven't got the right triggers. I don't know, but when we're talking about joint disease, millions of stem cells just sitting, looking at a buffet and not eating is almost
Yeah.
it's like what are you doing? And we don't know, but we know you can turn them on.
Mm.
There's some good research out of Leeds University actually showing that those cells that are just sitting there latent, and millions of them can be shed into the joint by doing really simple maneuvers when you're doing an arthroscopy, for instance.
Oh.
Um, so yeah, I think they're patenting that, and they've published some of that research. And but again, it hasn't got to clinical level. No one in the country is doing what Leeds have published on over 10 years ago.
Oh, 10 years ago.
Yeah, yeah. And this is the problem, the rate of research. When you sit and, I sit in a research department in a big university, and the amount of, projects, universities have become commercial bodies.
Right.
The days of, a professor having a lifetime project and spending 20 years trying to discover something, I think is long gone. What
Really?
happened now is, you get funding.
Mm.
Funding drives the research,
Mm.
understandably to some extent, but
Yeah.
then your funding runs out in 3 years. So whatever you're doing for those 3 years, you'll do.
Yeah.
And then if you don't get ongoing funding,
Yeah.
you move on to the next project, and
Yeah.
everything you did for 3 years gets parked.
Yeah.
It's almost
Yeah.
about. And so within universities in this country, there will be shelves uh, and rooms full of amazing research and things that could affect the human condition hugely positively in every sphere, whether it's psychological research or joint arthritis or engineering, which is
Mm.
sitting in PhD theses on shelves that will never be looked at again.
Wow.
And this is maybe where one of the huge low hanging fruits of AI might be is that if you can feed all of these
Yeah.
projects into AI and sort of get it to read them and say, well, tell me, which one has the highest potential to develop into something that changes humanity for the good. You may well pick up some of that stuff because humans just don't have the capacity to do it.
I'm thinking of the stem cell, what you were describing earlier, and I was listening to what you were saying on other recordings as well. Is it kind of like we said about paramedic earlier, but also with what it can do and what it knows, like the AI of the cell world, because it's a bit more potentially knowledgeable, has more function?
Well, I think what they have is they have a higher order drug cabinet.
Right. Ah, okay, okay.
And I mentioned that we call them medicinal signaling cells, and the reason is that it's like they're like a drugstore. They contain
Mm.
so they're an intelligent drugstore owner. It's they are packed with all the right messengers that they need to
Mm.
do to deliver a response or dampen a condition or upregulate another something. So they've got all the tools. They just need to know how to use them. And so when they read that environment, they can actually then release the correct packet of signals to create the effect required. Some of that may be to dampen something, and some of
Mm.
it may be to upregulate and increase something. And that's sort of how they function. And what's interesting, as I said, if I inject stem cells into your joint, and if you look for those stem cells weeks or months later, they're not even there anymore. They've gone.
Oh,
So
really?
what they tend to do is they go in, they interact with other cells, they create that environment by releasing all those signals. Some of those signals they actually bind to macrophages. The macrophages will actually engulf them,
Mm.
and they can take over. Interestingly, a bit like a ghost cell, they'll take over the macrophage and use the macrophage's more powerful immune abilities to release the signals that are required to modify. And that's one of the words that we use with stem cells a lot is immune modulation.
Right.
And that means and immune modulation is a reason you can sometimes get long-term effects. If you do something that's anti-inflammatory,
Mm.
but you've got something that's creating inflammation, what happens is as soon as the anti-inflammatory effects die down, the inflammation comes back up again, and you're back at square
Mm.
one.
Yeah, yeah.
And hence, if say a stem cell only did anti-inflammatory without reprogramming, and that's where the immune modulation comes in. With immune modulation, we're actually talking about cells reprogramming other cells to function differently, and
Yeah.
that means an exchange of RNA and DNA. So you're actually reprogramming nuclei, which means that even the next generation of cells will be slightly different. The reason that,
Mm.
for instance, a stem cell injected into a knee might give you 3 years of relief rather than 3 months is because it immune modulates the environment. It reprograms those cells to behave in a different way. And that reprogramming stays. There's a DNA memory to that effect. And that's what we call by immune modulatory. If they were just anti-inflammatory, they'd drop the inflammation for 3 months, 6 months, and it'd all be back. But they last longer than that. The effect lasts longer than that. And so one of the theories that it lasts longer is that they're immune modulatory. They reprogram cells at an RNA DNA level. And that's why you get 2, 3, 4 years, sometimes longer effects.
But actually, on that subject, because about expected outcomes, so we will have more people coming in asking questions about these as they're coming more awareness is increasing. People will ask, and we'll take the example of someone with arthritic joint, but perhaps they're too young for a suitable surgery, or it's for whatever reason not suitable, not appropriate. And they say, what could this do? What's the expectations with stem cells into this joint? What should people say?
That's the golden goose question, right? Really. And even myself, when I first started using these, I thought, wow, they sound amazing. Maybe we're going to cure arthritis. Maybe we're going to, really reverse it and see regeneration. Maybe we're going to put them in and it's sorted somebody out for 5 or 10 years. We didn't see that. Okay. So what we've actually largely seen is an anti-inflammatory effect, certainly an effect. And again, you wouldn't know that if you didn't try it, right? So I think the rest of the world sort of initially was attacking people doing these early research, but that depends on your regulatory environment. We are an innovation stunting nation in the UK.
Yeah.
And that's because we call it responsible research. Responsible to who? Right? Responsible to who? And so one of my arguments to that is that if we actually have no cure or no answer to a disease, and somebody has something that may potentially affect or change that disease, the correct approach, in my view, is something that, for instance, Italy and so other countries do it differently. So I've seen Italy and Japan that what they all do is they say, well, we don't have a good solution to this, and now Ben has now invented something, and it may or may not work. Ben can either go away and spend the next 5 or 10 years researching it, and do a phase 1, phase 2, phase 3 clinical trial, which you'll have to raise millions and millions and millions of pounds in capital to get anywhere. Or Ben can actually think, this is a really good idea. There's predicate information, for instance, this is pretty safe because it comes from Ben, i.e. say with PRP, we make it from patients' blood. There's nothing really harmful in it. It's an injection made from growth factors made from your blood. So as long as the processing is safe, what harm is it going to do? The harm risk is tiny. Okay? And so if something makes sense, but you don't know if it works, what, for instance, Japan's regulation says is do a small study, 50 or 100 patients, prove it's safe. So they can do a small safety study where they can do 100 patients, whatever the regulator decides is appropriate. And for some things, it may be 1,000 patients, but they let you do a safety study. You follow everyone up for 1 or 2 years, and you show that no harm came to them. Right, so no harm. So you've done a small safety study, and now you get to use it in patients. Because what they'll do is, as long as they've got a system whereby they track the outcomes of these trial interventions, you prove safety, and then you use it in the equivalent of their NHS. They will actually tell you, because there's no solution for knee arthritis, and the treatment gap. So if you're 75 and your knees bone on bone, you've got deformity, and you're retired and you're low demand, knee replacement's absolutely the right thing for you. But put that same scenario now in a 25-year-old. What's your solution? The NHS doesn't have a good solution.
No.
Conventional medicine doesn't have a good solution. And it's like, well, painkillers, take these drugs now for the next 10, 15, 20 years with all the problems and side effects that they may create. Or use, there isn't one, right? So whatever alternative are steroid injections or surgery in a 25-year-old, knowing that once you operate on the 25, when they run around on that, within 5, 10 years, that joint's going to fail. and they're going to need a revision at 35. And you're going to put another one in them at 35, and you're going to put another one in them at 45, and another one in them at 55, 65. It's
Yeah.
surgery forever. Each surgery gets more complex and more expensive with
Yeah.
a lower out return for the patient. So we don't have a solution. So in that scenario, why is it that you, for instance, couldn't try something that may be seen as experimental but is safe?
Mm.
And that's their viewpoint. So they're like, well, we will let you now do this on, say, 500 or 1,000 patients within our regulatory environment, and we want you to monitor all the data. So they provide internal governance, and they let people try things. So they'll then put, say, 1,000 patients through a procedure, which would be very difficult to do outside of a National Health Service system. If you ran that as a private trial, as I said, you have to raise 20, 30 million in clinical trial revenue to generate that sort of a trial. Um, the administration of a trial that would cost you 2 or 3 million. You never mind that. That's without injecting anything in anyone. Just the administrators would charge you that much for that kind of a trial. And so it avoids that huge burden of proving something that's is already safe. And if at 1 year it's not working, they've now got the data. They can just bin it.
Yeah. Yeah.
But they're willing to take that slight risk of, we'll let you try it on NHS patients because you've shown it's safe and it may work because it makes sense. And there is some signal that is positive, whether it's animal studies or early clinical research. And so they have a slightly different appetite for risk. And that's why they're way ahead. In Japan, there's 200 stem cell clinics all across the country, at least.
Ooh. Wow.
And their stem cells are widely used because they've got good at it very quickly. Because they allowed widespread adoption once they proved it was safe. But those clinics have got excellent data. They've got data on lots of conditions, from whatever it might be, from saggy skin to joint pain to rheumatoid. They've got data on all sorts of conditions, which the rest of us don't even have because we haven't even done any of those trials. We're relying. We haven't allowed anybody to do it unless they go and get funding from NHR for millions of pounds. And when we compete for NHR funding, it sounds like it's a fantastic organization because most of the time it is, but they only have so much money.
Yeah.
Their priorities are set. And most of the funding goes to the priorities. If you come out with something that's a slightly left field, even though it's a common problem, they'll think that's too risky a project, and they won't give it to you. They'll give it to the orthopedic surgeons who's putting another bit of shiny metal in somebody. See if that works better than the previous bit of shiny metal. And I've been through that process. You can see my frustration. You spend months developing a grant application and it just gets nowhere, and then you rehash it and do it again. And my most frustrating element of research is that you then get the funding. I've been involved in successful grants, and then they'll give you the money, but then they'll say, but do you really need to do this? And do you really need to do that? Because their job is to make it as cheap as possible. What you find is what you've asked for to deliver the answer to the question gets crunched to a point where your deliverables drop and drop and drop. So you often end up in a position where you're accepting money from them to run a trial now that's been degraded to a point it won't even actually answer the question that you wanted to ask it to, that you wanted it to answer. And it gets quite frustrating, So the world needs to change in the way it does research. Randomized controlled trials are the gold standard.
Yeah.
They're too expensive and they take too long to deliver. So if we're going to wanting to keep doing them, we need to change the model in the way we're doing them.
If a patient were to ask, when do you think we may see them in the NHS for joint pain?
The NHS lags at least 10 years behind most of the rest of the world when it comes to like innovative, unless we invent it. So some research we are doing and we're pioneering.
Yeah.
But we invent it, it might take 5 or 10 years to eventually get a product to market. If it's come from elsewhere and we're dabbling with it, just because of costs, you're a physiotherapist. I can't get a physio on a weekend in my hospital.
Probably not outpatient. Probably no.
So patients don't stop needing rehab on a Saturday and a Sunday, right? So, and what I'm saying is, even acute care, I'm operating on a Saturday and a Sunday.
Yeah.
Those patients can't get physio on a Saturday and Sunday after I've operated on them, and that's a complete no-brainer. Complete no-brainer that actually, if we had rehab services available on a weekend, we'd have a shorter length of stay, we'd have better outcomes potentially for patients. And there's so much data supporting that. And yet the answer is always, oh, well, there's not enough physios and we can't afford to pay them to come on a weekend. Okay, fine. So there's something as lowbrow as that, which is a complete no-brainer, the NHS won't fund.
Yeah.
And so to then think, well, there's something. What is interesting in the cell space and PRP is that why is it expensive?
Don't know. I'm no idea because it's unique.
I'm using your blood and your cells.
Yeah.
You're giving me permission to take them. I take them with a needle most of the time.
Yeah.
And it goes into a syringe, and we use a simple device like a centrifuge to spin them and prepare them. So why are they expensive? I mean, when I go to places like Africa, you know, up in Tunisia recently, we can produce PRP for sub $5.
$5.
Yeah, cheaper than that in reality. You know, in low income countries, I've trained people to produce PRP in syringes with a bit of anticoagulant. You know, for $1-2 costs.
Really?
It takes a bit of time, and we use it in wounds. We use it to heal wounds that won't heal, or as dressings on complex ulcers, and it works beautifully. And but we're in a position where obviously our regulatory environment demands something's gone through a certain medical device directive, has to be CE marked and FDA approved, or whatever it may be, whichever country you're in.
Yeah.
By the time a company gets through all those hoops, they've had to spend £500,000 to £1 million in research and development costs, and suddenly they're now selling you a needle in a pack with a posh syringe for about £300. Right, to recover those costs. Those things are, you know. So I won't take you on a lengthy journey where I have proposed the NHS. I could produce NHS stem cell collection systems and NHS PRP tubes, which would cost £5 or £10. And once that paradigm comes in, you know, it becomes a no-brainer that we should be using them, but we just don't have the vehicle or the mechanisms to monetize this kind of service in the NHS, which is a real shame. I've tried.
With the stem cells, are pharmaceutical companies not behind it at all or not interested?
The difficulty here is that pharmaceutical companies only interested in something they can patent.
Oh, they can't patent. Oh, no.
Yeah, how do they patent your cells?
That's a good point. Yeah.
Especially if they are patented for simple processing. So if I'm just concentrating them and putting them back in. So pharmaceutical companies are looking at cells, but what they're wanting to do is produce them in a particular way or engineer them in a particular way. And that is the future of this space. The future space of cells will be engineered cells for a particular condition.
Okay.
The stem cells, as I said, at the moment, we're using them as slightly a blunt tool.
Yeah.
A very clever little tool, and they can, as I said, read an environment and produce specific responses. But actually, is a bone marrow cell the best cell to put into a joint, or a fat-derived stem cell the best to put into a joint? We don't actually know. Is an umbilical cord cell the best one to put into a joint? Or do we produce cells that we know produce a particular signal that's for arthritis? So we're going to have to find those. That's why there's lots of different types of stem cells out there. There's lots of ways of engineering them and getting them to actually produce particular signals for a particular condition. So I know some of the really cutting edge stem cell labs are now producing, for instance, they found that neuronal conditions. So if you want to look at neurodegenerative or Alzheimer's, you need, you can put stem cells in and they may have some effect. But if you get stem cells that have been engineered to produce neurogenic growth factors, you get potentially a more enhanced effect. And so that's where the work is now going, you know, preconditioned and specifically engineered cells for a particular problem. And that has to be the future of the space, really. And the people are already looking. They've been looking at that for a few years, and now labs are producing preconditioned cells with a particular output. And obviously, your cells and my cells may have a different output.
Yeah.
This is personalized medicine, it's precision, and not everyone's behaves. So you'll actually, you know, at some point, the pharmaceutical companies may find a super donor whose
Ah.
whose neurogenic stem cell growth factor responses are 10 times more than anybody else's. They will then produce a patent around those cells and the way they engineer them, and they can license that product as a drug.
Mm.
And suddenly they've got something that delays the onset of Parkinson's, for instance. And
Do you think?
they can monetize that. And if they can monetize it, they're interested.
Yeah.
Fortunately, I'm going to be slightly horrible to big pharma, but they're in it for profit, right? That's
Yeah.
what they exist.
Yeah. Yeah.
Um, if they can't monetize it, they're not interested.
No. Do you think that may, talking about the delays with the NHS and regulatory stuff, if they get interested and have their funds, may that speed up it's a dark thing to say, but may that speed up the process?
Absolutely. I mean, the thing that will speed up the process is having more money, more
Yeah.
research. And the biggest thing that would speed everything up is collaboration,
Ah,
right?
but
But people don't collaborate. Universities don't collaborate, they compete, okay, with each other.
yeah.
And there is collaboration when they're doing grants where they're all sharing the money. They'll collaborate, but they'll collaborate for the point of that or the time point of the project. If it's 2 years or 3 years, and then they go off into their own laboratories, and then they work on outdoing each other.
Yeah.
Even academics are actually inherently competitive, and we think that they're doing altruistic research to find a cure for breast cancer. They're all competing to find the best cure for breast cancer. What would make sense to me at a human level is that every bit of breast cancer research around the world is shared,
Yeah.
and there are collaborative projects and meetings. That's where I think AI and machine learning will really help
Mm.
medicine. I mean, we're just entering a golden age of medical research, and that's going to be with the help of machine learning
Mm.
and AI. Because I mean, you have to. I gave a talk on AI again at the British Orthopaedic Association a few years ago,
Yeah.
and I always start off with saying, remember, there is no such thing as AI. There is no artificial intelligence at the moment.
Mm.
It's not artificial intelligence. They're just machines that have been taught and learn based on an algorithm that we feed them. True generative AI has yet to be born. There isn't
Ah.
artificial intelligence. They're just very, very clever machines. And what's happening now is the machines are getting accelerating, and they're learning, or they're now producing algorithms using the algorithms we fed them, but because they're allowed to adapt those algorithms, they are now actually producing outputs that we're not even aware of how they got there.
Yeah.
And
Okay.
that's what's getting interesting slash slightly scary,
That we
uh,
don't know. Ooh.
because they can
Okay.
manipulate the algorithm we've given them. They are
Mm.
now changing it to learn quicker.
Yeah.
And now the outputs are being produced by large corporations. And if you ask anyone in that corporation how that output was achieved, the answer is often now, we don't know. We just
Really?
we just asked it to do this, and we don't know how it got there anymore.
Oh.
And that's the interesting side of this. And yeah, AI can be um, a robot who looks after you and helps cure disease, or helps you operate, for instance, et cetera, at the benign end, and it will help us accelerate the learning around research and
Yeah.
cell therapies and how they affect patients. The rate we will learn at will accelerate enormously, and that's why it's a huge golden era for medicine in the next 20 years. I expect to see, in reality, medicine moves really quickly. On the
Okay.
ground, it doesn't,
Mm.
right? On the ground, it doesn't, right? So the researchers and what we are learning, if you look at each decade since the Industrial Revolution, it looks like we've made huge strides. But actually, those strides are going to look like crawling, tiny little ant steps compared to where AI will take us actually in the
Mm.
next 10, 20, 30, 40 years, 50 years, 100 years. With the potential to double your learning in a shorter period. I think
Yeah.
medicine enhanced by double, say every maybe 10 years
Wow.
over the last many decades, but we're going to move at a rate of knots quicker than that soon.
I say this to my colleagues all the time. It's going to be very interesting to see whether it's physio, doctor, psychologist, whatever, looks like in 10, 20 years time compared to now?
The way somebody described this to me, because I didn't quite fully understand it, but I've been paying some attention to AI. It's that it raises the bar for everybody, all at the same time.
Mm.
Okay, and that's where, so you and I may get a little bit cleverer. We might find it's a bit easier to do our research and develop things. But if you and I are having a conversation about stem cells 10 years ago, you'd be reading, or 20 years ago, you'd be reading a book and trying to do prep for this topic. If I speak to the leading stem cell scientists in the world, I feel like a complete novice. But actually, what I could do now is jump onto whichever Copilot or Gemini
Yeah.
and do a bit of research and say, tell me just list for me the top 20 conundrums about stem cells and what the future holds. And it will read the entire internet and find 20 questions for me and make me sound super intelligent. But it's not just that it makes me sound super intelligent. I'm actually learning. When I read those questions and think, wow, I didn't know that. I didn't know that. I didn't know. Suddenly my level of understanding has jumped in 20 minutes. There's something that would have maybe taken me days or weeks previously. I've jumped up in 20 minutes. And if imagine now if there's 10 scientists meeting in a room and they're all working on cancer research, but in a slightly different angle, and they don't really understand each other's bit, but they go away and do a little bit of AI assisted research and turn up in the room with a slightly elevated understanding of each other's work, and then go away and use AI to increase that a little bit more, what you'll find is the actual progress they can make from a knowledge perspective starts to accelerate rapidly. And it's across the whole group, as I'm saying. It's everyone lifts everyone else up. And that's where the real promise, I think, of human development in this space is. But obviously, there's always the risk of Terminator scenario as well.
Well, as always, yeah. Actually, I tell you what, speaking of risks, if we've talked all about what it does and what it can do and achieve, if someone was to ask what are the risks, you were saying about the Japanese and what their studies they'd done, are there any major risks
So
for stem cells?
the reason regulators clamp down on stem cells is because they have the ability to change the way your cells are programmed.
Right.
Okay. And what we do in the UK currently is what we call mini manipulated cells. So what we currently do most of the time is we take cells from you, we clean them and we process them and we concentrate them, so that we've isolated them and cleaned them and concentrated them. We haven't turned off any safety mechanisms. The way simplest way I describe them to patients is when I'm talking to patients is it's a car, and we've engineered a car. It's a nice new car. It's got all the safety mechanisms still intact. Airbags, brakes, all working. That's the cell that we now currently use in the UK to put back into people. And a cell from you going back into you isn't going to create an immunogenic response. It's your cell. And if it delivers an anti-inflammatory or a immune modulator response, it's still delivering it in a controlled way because its brakes and airbags and all the safety and ABS are all intact. Everything's still working because we haven't taken that off. When we take those same cells, put them into a laboratory and want to expand them to make many more of them, we have to remove the airbags and brakes.
Okay.
And we've now got what we call induced stem cells. We're making them in a laboratory and they're expanding rapidly. And the worry is that as cells expand, each lineage, each line, there's a bit of RNA, DNA degradation.
Okay.
So when they expand the first time, they're in a pretty good state. They're a pretty good clone of the previous cell. The second time, they're pretty good, but maybe 90%. I don't know the exact figures, but say 90% of the previous cell. The third or the fourth line starts to degrade now. You might be 80%, maybe 70%. And each time they duplicate, they degrade more. So once you go past, so there are certain laboratories, that I know don't go past the fourth lineage, they stop because they know the cells degrade after that. And but if you've got a degraded cell, you've got potential danger. Its DNA and RNA may be abnormal. What the program it sends to your cells may also be abnormal. So the worry the regulators have is, are we going to, in 20 years' time, find that we put stem cells in people and they all got cancer? Yeah.
Okay.
And also because there's such a rich source of growth factors, there are cases in the literature of somebody who had a stem cell treatment and then developed a cancer, say 5 years later. Did the stem cells cause the cancer? Probably not, is the reality. We have actually been using stem cells in medicine now. As I said, the first stem cell transplant happened before 1960.
Okay.
But we've
Yeah.
got lots of predicate, research we can look at. And most people that we did those things, if you've got blood cancer, and someone says we're going to give you a stem cell transplant, but it might give you cancer, you don't really care because you're going to die without the treatment,
Yeah.
right? If you
Yeah.
end up with lung cancer 20 years later, I mean, it's better than dying in 2 years from blood cancer. So people, I suppose, in that scenario, it doesn't really matter. It's necessary. But for over 20 odd years, if you look at all the regulatory research, there's virtually no clear risk of stem cells causing cancer as long as they're not heavily manipulated. And that's why they have this minimally manipulated rule in the UK. But even the expanded cells, the problem is there's no gold standard. Everyone does it slightly differently. You'll get different stem cells in India to Japan to the UK because we have different rules. And some people believe in really high dosage. They'll make 100 million or 200 million cells for delivery. Whereas actually, how many do you need? I don't know. You don't know. Yeah, nobody in the world knows how many you need.
Oh, really?
There are dose-related studies going on. Some people are saying, well, but then it's dose-related by which cell? So which cell are you using? Right,
Yeah.
you're using different cells. They're from different sources. So the simple answer is you don't know. When we do clinical research and we've used 1 million cells versus 2 million of a different cell, we found no difference clinically. The patients respond the same way. And the other elephant in the room is the non-responders. They don't work for everybody. If you've got arthritis and we put stem cells in you, I would say to patients, 70 to 80% of patients have a positive response. What's a positive response? What we call a positive response may be different to what you call a positive response.
Yeah.
What do we call a positive response as researchers in this space? We call a positive response at least a 50% reduction in pain.
Okay.
Right.
Yeah.
So somebody gets a 50% reduction in pain. So it's not a zero pain.
No.
And so you have to make that very clear to people, manage their expectations, and say, well, if you drop your pains, daily pains go from 6 out of 10 to 3 out of 10, that's a good result to us. If we don't achieve that, it's still a positive result because you may have gone to 4, but we don't call that a good result. When I say good results, 70 to 80% patients get a good result. That means they get a 50% reduction in pain. How long does that last for? The average length we found in our hands that stem cell treatments work for is around 18 to 24 months.
Okay.
PRP, average length of treatment, around effects that achieve the same 50% reduction in pain. Average length of efficacy and treatment average is about 14 months in my hands.
Okay.
Obviously, that means some people are going to get 6 months, some people are going to get 24 plus months. And that's why the average falls down around 12 to 14 months. But there are that 20, 30% I've just mentioned who it doesn't work for. They don't get the 50% reduction or they almost get no reduction. And so why are they different? And that's the elephant in the room.
We don't know.
I think that's going to come down to poor preconditioning. They're
Okay.
probably inflammatory. They've got metabolic syndromes. If you're obese and your diet's really poor and you're in a metabolic inflamed state, the cell's probably not going to do it for you. Or if you're in the opposite of that, some people don't have pro-inflammatory arthritis. They have truly mechanical arthritis where there's minimal inflammation in the joint. And if you don't have inflammation and the cell's primary function is anti-inflammatory,
Yeah.
it probably doesn't help them very much. And so we need to start learning to pick our winners and losers. And what's going to give us that is big data. If everybody collects all the data on every patient that ever gets injected around the world, very quickly, AI and machine learning will tell you, especially if you can feed in medical records into those patients. So it'll start to pick up patterns. It'll say, well, people on these drugs don't do very well with this treatment. People with these medical conditions don't do very well with this treatment. People with this BMI don't do very well with this treatment. And they'll start to then predict out and select out the people that we think it'll work for and it won't work for. But that research is being done, but at a low level. It needs to be done en masse. We all need to start collecting that data, entering it into registries, picking out the patterns, and that's what will teach us. In the same way, people sort of say this is experimental. You know, half the operations we do are experimental in the sense that when you do a knee replacement on someone, you give them an 80% chance it's going to help them. They're going to get a good result.
Yeah.
It's the same result I'm achieving with an injection.
Yeah.
You know, but a knee replacement, there's no way back from that. There's no repeat.
No.
No, once you've had it, you've had it. If you're in the 80% now that are happy, great. If you're in the 20% that are miserable with it, what are you going to do?
Revise it, maybe.
Yeah, revise it, and then they might still be miserable.
Yeah.
Nobody offers guarantees to these patients yet.
No.
Yeah, strangely enough, people want some sort of guarantee, and the reason life doesn't come with a guarantee,
No.
and the treatment results don't come with a guarantee, but in the same way, surgery doesn't come with a guarantee.
No.
If you're in that 1% that gets a deep infection, it's 100% for you.
Yeah. 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 Absolutely.
And you'll now be miserable and wish you never come to the hospital for the operation.
Yeah, you're absolutely right. But that's why you have to discuss the pros, the risks, isn't it, clearly, and make sure they have to
Absolutely.
go through that with them.
So, I always start my consultations with very, very clear. What do you think the treatment's going to do for you? So I obviously the patients turn up with preconceived ideas. So I usually actually challenge that, and I'll say, "You come to this clinic. What is it you're interested in?" And they'll say, "Stem cell or PRP or whatever it might be. That injection, that injection." I have, we've almost got too many options because we pioneered this space in the UK. It's getting to a point that even my own clinical team are slightly confused because I produce customized PRPs, so I've got 8, 9, 10 different ways of making PRP. I have 3, 4 different types of stem cells available. I have hyaluronic acid, steroid, arthrosamid, hydrogels.
Yeah.
We've got like 10, 12 injectable options for a patient. So we specialize in joint preservation. So before you get to joint preservation, before you need a knee replacement, we potentially have a menu of 7 to 12 options of it.
Yeah.
So what are you going to choose, right? And we've got data on all of them, and so it can get a bit confusing for patients, right? So to try and sift through all of that information and go, well, actually, I want that one, but we do our best to guide them because obviously I've been doing this for a while, and we've treated thousands of patients across multiple territories, and we sort of have got. But I say to patients openly, I said, your disease is individual to you, your genetics and epigenetics are individual to you, your arthritis is individual to you.
Yeah.
Your knee arthritis is not the same as the next person that walks in the room. Neither are you. Neither is your diet. Neither is your microbiome. All the things that actually affect your outcome are individual to you. And so when I treat you and we decide to go for XYZ treatment between us, we're going to agree the treatment. Your result is my best guess. I said, so I'm guessing what's going to be the best treatment for you, and you're relying on my best guess. But somebody who's done this 4,000 times is better than somebody who's done it 40. So I'm just a better guesser. You're going to go and see.
Yeah. That's come to my real as time has gone on as well clinically. I've come to realize a lot of what we do is, as you say, best guess, the most likely. It's
That's
never
life, isn't it? I mean, life is, that's how we live life. That's how medicine is. We have a differential diagnosis and then we try.
Yeah.
I remember doing cardiology as a house officer and walking around and weighing people and starting them on one water tablet. Here's furosemide, and you weigh them the next day and you ask them about their side effects, and they're like, "Oh, well, I'm not doing very well, and their kidney function is getting worse." And you go, "Oh, let's stop that one and let's give you this other one."
Yeah.
And you come and weigh them 2 days later and check their kidney function and is your breathlessness better? And what's the AKI like? And and it was like I was sat there thinking, this is like, why don't we know what to do with these people? Why am I trying one drug and then that doesn't work, and then trying a second, then trying a third, then adding a fourth, and then and it felt to me like I thought cardiologists were really clever and they knew what to do. I'm doing this ward round, and all I'm doing is changing pills every day, and we don't know how to fix people. So I sort of left there thinking, and then every specialty I've gone through since then, it's the same, right? We're all there like we're doing our best guess. And then that doesn't work, and then we go for best guess number 2 and best guess number 3, and that's how we practice medicine. Until we can read with our eyeballs molecular health in a cell, we're never going to get any better. And we're many decades away from that, if not centuries yet.
Definitely. Are there common conversations about stem cells and things that come up that we've missed that you wanted to say that patients may bring up?
Um, I think knowing that the keys are knowing that it's not a miracle cure,
Mhm.
knowing it should be part of a potential treatment plan in patients. And it's not just about stem cells, it's about all the other injectables. So I think joint preservation clinics should be available
Mm.
in every region.
Mm.
And there should be one clinic that patients get referred to, NHS and private, whichever way you want to look at it, where people have got the skills and the knowledge and have learned how to preserve joints. And young arthritis, or whatever you call it, young arthritis clinic,
Mm.
because I know they exist. There are some
They
young
do.
arthritis clinics in the
Yeah.
NHS, but they tend to be either physio or young surgeons who have a slightly special plastic for a younger patient. And that's it. We're missing a trick because in between there's an awful lot else you can do. And I'm not even talking. There should be multidisciplinary. There should be pain management built in. We
Mm.
do like genicular nerve blocks, radio frequency ablation or modulation, genicular artery embolization. There are so many other things.
Yeah.
Osteotomies, joint preserving surgery. We already think within the orthopedic community that probably the tibial osteotomies that we do, so realignment surgeries for knee arthritis, probably should be offered to thousands more patients every year than we
Mm.
actually offer them to them. Why are they not being offered? Because the surgeons aren't trained to do it.
Oh,
Uh,
okay.
and they don't know how to do it. So again,
Oh,
within each region, you tend to find there's two or three people who know how to do that operation, but there's 50 surgeons that can do knee replacement.
yeah.
So what's a patient going to get 47% of the time? Yeah, sorry,
Yeah.
47 out of 50 consultations are going to lead to you need a knee replacement. Whereas
Yeah.
actually a significant proportion of those patients could have kept their own knee and just had realignment surgery.
Mm.
So we're not doing a lot of things very well. But that's the issue with the resource strapped system.
Indeed.
It's there's only so many doctors, there's only so many hours in the day, and there's only so much the NHS can fund,
Yeah.
and it has to make those difficult decisions. So I understand where it comes from, but you would have thought joint preservation should be a really core part of training in
Mm.
orthopedics or general practice, and it just isn't.
No, no, you're right. I've been talking about the future a lot. I often finish asking about the future. But as you and I were talking earlier before we hit record, we were still talking a bit about steroid injections, and I was wondering, as we were talking about the future there, if as time hopefully goes on and these things get used more and more, and it goes through all the checks and passes, could potentially stem cell injections be the end of steroid injections?
Yes,
In short, okay.
it should already be. But the difference is just cost and availability, right? So what will happen? Um, you can already buy stem cells in a vial.
Really?
The companies in the United States are selling it. Other parts of the world where they've cultured cells
Mm.
for arthritis or for skin conditions or whatever it may be. So that they've produced them. Korea's leading in some of this, and they're available in a vial. They're frozen down. They're potent. They're viable. They're active, and you can literally buy them, suck them up in a syringe, and inject them.
Mhm.
And this is, as I said, we're really only scratching the surface of what we can do with cell programming. So in 10, 20, 30 years' time, cell production will drop in its cost,
Okay, yeah.
right? There will be a natural mass market of cellular products being available, certainly in some parts of the world.
Mm.
And so once the production cost goes right down and people can buy them in vials and inject them, why would you? I mean, if I had a choice today, there's no way I'd let anybody put steroid in me if I could have PRP or stem cells instead.
Mm.
For me,
You've
that's a
saved them.
no-brainer as somebody who's seen the results of both and has been in
Mm.
this space for 15, 20 years. It's not even a choice, but I know there's a cost implication and a harvesting implication and a time implication.
Yeah.
And that's where the consideration comes in. If you had a choice right now, if somebody's just showing you a blue pill or a red pill, and one was, a vial of stem cells and one was a vial of cortisone, it'd be a no-brainer what you'd go for.
Mm. Interesting. Interesting. Um, so so people can find out more. And I'm very grateful for this, by the way, and thank you for your time. You're on Instagram LinkedIn.
Instagram only this year.
Yeah.
I'm actually I've generally been a last 10 years a hater of social media. I think it's one of the great ills of society. But at the same time, it's a great way to get information across to people.
Mm,
And so I told you only 24, 25 if I had any focus on proper private practice.
mm,
Um, and getting the research information we have out there. And the team I spoke to said, look, there's no better way. I'm afraid you've got to suck it up if you really want to get your information out there. You're going to have to get on
yeah.
Instagram and LinkedIn and all the rest of it. So LinkedIn, I've had an account for a few years, but I didn't even have an Instagram account until 2024.
Really?
Yeah.
Anywhere else you are for socials?
Sorry. So
Any
uh,
other socials?
it's just Dr Ansar Mahmood on Instagram. And our clinic is called Kaizen Clinic. So it's just Kaizen from, the philosophy of the Japanese philosophy of uh, perpetual improvement. So it's
Yes,
organic
yes,
theory. So Kai
yes,
and Zen are two words. Kai means ongoing or perpetual, and
yes.
Zen means improvement.
Ah,
Again with cell therapy and I don't use it in isolation. We precondition patients. We put them on anti-inflammatory diets. We do genetic screening and epigenetic screening. We try and look at their microbiome. We boost treatments with shockwave, hyperbaric oxygen therapy, because all of these things coming together in
mm,
result is not, just putting cells into somebody isn't the way forward. We started off obsessed with the soup of the cell. Whenever you start doing anything new, you sort of, we're how many cells do we have? How viable are they? Can I make 1 million to 2 million? Can I, and we did that for 2 or 3 years. And after a while, we sort of thought, what's the elephant in the room here is the patient who is inflamed and rubbish diet and they got metabolic syndrome and their sugars aren't controlled. And, we actually really need to optimize the patient. So we actually produced a principle called preparing the soil that my Brazilian colleagues published on. And they've shown that, within 2 weeks of adjusting somebody's diet, you've got a completely different inflammasome for that patient.
really?
What's interesting is sometimes I put patients on anti-inflammatory diets, as I call them, and they've actually not needed the injections anymore.
Really?
Yeah, just adjusting their diet,
This is just the
and then
diet.
yeah, their knee pain drops, and they realise actually, it was part of what they were eating. There was a
Yeah,
problem.
yeah. That will also be interesting to see how, as things move forward in the years to come,
Yeah,
food,
if you look
that
at
stuff.
microbiome data in the last 10 years,
Yeah.
that's a research area that's skyrocketing. It'll growing
Mm,
exponentially. People are realizing that, the actual amount of DNA in our bodies that is ours,
yes.
Ben's DNA is the minority. The foreign material you have in your body is the predominant DNA material
Mm,
sitting in your body as an organism, and the
mm,
interaction between your RNA, DNA, and signals and the foreign DNA is actually probably driving an awful lot of your disease processes and inflammation.
mm.
So you have to learn to communicate really well with all these visitors that allow your body to function. And so that research is super exciting at the moment.
Interesting. Are there anything else you'd like to plug for yourself? Socials, the place, any courses or anything like that?
Yeah, yeah. Well, I founded the Academy of Regenerative Medicine in the UK. We're still the only dedicated provider of training in what we call orthobiologics. But so I teach the Academy of Regenerative teaches doctors how to harness regenerative medicine principles for their patients
Mm,
in the skin space, hair loss space, orthopedics, sports medicine, and that's what we
mm.
teach. So and the academy just called the Arm, and our Insta handle is at Regen Academy.
Okay. And
So anybody wants training, have a look on there. We're just about to redo the website, but the old one's still live. Uh,
and
and I enjoy educating in this space, and have been doing it for a while. So
it would be very, like I said all along, it's going to be very interesting to see what the next 5, 10 plus years
absolutely,
will look like.
yeah.
I can only thank you, sir, for your time again.
No, you're welcome, man. Thank.
And yeah, thank you very much.
No worries. Take care. Thank you.